step one. Step one is please briefly, and I'll go through this and then you guys can start. So step one is please briefly introduce yourselves. Take a few minutes to read the information sheet at your table. There's going to be a sheet on your topic. So the purpose of this focus group is how do we put those on the road here in California? How can you employ those strategies in the work that you do every day? Those are the ideas that we're looking to harvest from today's focus group. So then, once you've had a chance to review that, feel free to pull out your small group worksheet, make notes if something hits you. As people go around and introduce themselves, once folks are finished introducing themselves and you've read through the information sheet, we're going to dive into the focus group. And I'm going to leave it to table facilitators to finish that part of it. And then I will let you know when it's time to move to round two. Okay, so step one, introduce yourselves. Step two, take a quick look at that information sheet. Step three, go ahead and dive in. And then just a little bit before you're about to finish, you might want to talk about what your group wants to leave as some ideas for the summary. All right, especially in the end of round two. So the questions that we're considering for each subject area that are on this sheet, it's what innovative strategies would address the challenges associated with your topic area. And then also feel free to share your ideas as well as strategies or mechanisms that you know are currently in use or development. Everybody have their topic area sheet? Okay, great. So that topic area is what we want you to focus on. And we're really looking for your ideas on what innovative strategies can be used to put those objectives on the ground. What can we start doing? We heard some of the challenges that were asked. What are some responses to those challenges? Does that make sense? Yeah. Okay. And then if you have any gaps that you identify that can be solved by or moved forward by research or by public policy, just call that out. All right. Any questions? So, again, what I want you to do is focus on what you put up on the board being things that are actionable. So if you look at a sentence you have up there, is that something you can do and you know what that is? If you don't, you're going to need some more meat on it. So that's what I want your evidence criteria to be for what you put on that board. Because the next step is people are going to say, yeah, I'm already doing this, or I think this is something I can add. And so we want it to be specific, something that they can measure, that they can understand. So make sure what you put up there is actionable. And if they weren't at your table, they would still understand it. And help out your scribes if they look like they have a quizzical expression on their face. So you're going to do it. So table facilitators, you're going to do a quick summary. Go ahead and have people introduce themselves. So do a quick summary of what the folks discussed before. Have people introduce themselves and then run through that whole thing again. Okay, folks, so are we ready to go? Who is going to be our first, do our first report out? Your juiciest, most innovative ideas. Do I have a volunteer? Okay, great. So we're going to start, but as you're listening, I want you to listen for, well, if I had some additional resources and I had some or I had some other partners to help, then this would be something I would consider. So I'll talk about how that's going to show up so we can all see it. But for now, just have that in your mind as you're listening to the ideas that people have developed. Okay? Diane, take it away. Introduce your topic.
Yeah. So our topic was service delivery and payment. And we came up with about 10 different ideas, but I'll limit it to about 6. So I think the first one is pretty juicy. This was our view that that a lot of times one of the problems with the healthcare system is that, like Dr. Jonas was talking about, that people see different physicians or providers and they'll go to one and they'll recommend something and it might work initially but then not work, and they go to somebody different and they have different recommendations, and what is needed is kind of on an, if you are a chronic pain patient, have been experiencing chronic pain for 3 to 6 months, that you're on your visit to a doctor's office that had would have an interdisciplinary pain group that would do your initial assessment. And that would be covered by insurance. And at the state level, that could be Medi-Cal, that could be the state health employees or state employee benefit system, workers' comp, the no-fault personal injury system, and it could be a state mandated health insurance benefit. Another thing we came up with was, although there's still going to be a need for research on different models of payment, and including convincing insurers that this is integrated teams make sense. So we want to have the state established, like this is something that I mentioned in my comments, something like the Stem Cell Research Commission, but as a pain research commission, where they would be funded by the state legislature. Then different researchers could submit grant proposals to look at the benefits of different interventions, of integrated care, of payment innovations. Another idea is a Medicaid waiver for state demonstration projects for integrated care. And this is something that other states have done, Rhode Island, Florida. Oregon has not gotten a waiver, but has done something like this, or expanded coverage. Also, again, California has a huge number of state employees, and they do the health benefits for those employees. So that could also be a potential pilot program looking at integrated or interdisciplinary teams providing services for that population. Also, insurance coverage for telemedicine. There are a lot of people who don't live near a provider who can give them adequate pain treatment. And then lastly, we thought that the state could fund a center of excellence, or have a pain czar at the state level, like Oregon, to really oversee and coordinate what's being done in the state. That's us.
Teaching wellness and self-care in school, college, for example, and to incentivize wellness programs. An example is like a Safeway type of program now, where employees are actually incentivized to exercise, eat well, and to have ergonomic assessments, to prevent low back pain, so on and so forth. So that would be one of the juiciest ones from the prevention area. The second bucket was on self-management programs, nationwide self-management programs for pain. And part of the problem here is that there are so many different programs that individuals and institutions are using across the country. There really are not collaborative approaches to this, so we need to identify the components of self-management programs, create a toolkit that could be used across institutions, study the outcomes with these types of programs, and really communicate those and market them to patients to incentivize them to use it. Also, we had an example at this table of a mandatory course that's offered, or it's mandatory for USC students, on self-care and lifestyle redesign. So again, changing the culture of the next generation so that we're teaching these types of things early on. And then for pain assessment and outcomes, again, going back to the conversation we had earlier, we really need to identify the outcomes that are most important to patients. So we need an initiative that takes into an account both pain scores, pain interference, but also the functionality that patients experience and what's important to them, and utilize that in outcomes-based research. So those are our three.
That toolkit got me excited. What can I say? All right, so who is our next reporter? No, really great work, you guys. These ideas are fantastic.
Yes, so our area was the disparities area. One of the major goals is to reduce bias and improve communication between patients and providers. We felt a linchpin here was education of both patients and providers to increase awareness of the impact of pain and to reduce bias. And there was some evidence that if providers are made aware of their biases, they want to change them, right? They don't have malicious intent, but we may be unaware of biases, and there are some innovative ways to do this. There's some research going on using virtual patients, that is computerized patients, to identify biases and then provide feedback to providers. And we heard another example of using a virtual reality application to enhance providers' awareness of their biases and try to reduce those biases. So we thought those were very innovative ways to address the biases. Another major issue is the fact that pain is not a priority in many public health spheres. Those public health arenas are where decisions are made about allocation of resources. So we need to do something to get pain higher on the priority list so that more resources are made available through these public health agencies, because they do a lot of innovative work there. One example of which was some group medical visits that are used to make increase access to care among patients from traditionally underserved populations, and also enhance the quality of care that they're receiving, because they're benefiting from the peer interactions, and indeed their providers are benefiting from the nature of those visits, both in terms of getting more information about their patients, but also in terms of reimbursement. There are ways to do this that are financially feasible. And then we also address issues of reimbursement, that many forms of care that would be more disseminable and available to patients and helpful to patients aren't well reimbursed by various payers. So there are gaps there that need to be addressed by changes in reimbursement policy, and it was clear that in order for that to happen, and we heard this earlier in the meeting, we need the evidence that these things are effective and ideally cost effective. So increasing evidence to identify treatments that are effective that should be made more widely available. And I'll stop there.
I think that was brilliant.
Let's give a big hand to table 4. Woo! Okay, so take us home.
There's one more after. No, this is the last one? This is the last one. Okay. So our topic was getting out professional education, and some of the ideas were to use research as an educational tool. The example was given that there's a yoga program, I believe, out of the University of Arizona that is being studied, and they provide this as a module to physical therapy programs to test and see how it works in their program, and that at the same time, of course, educates the physical therapists. So research could be one avenue. In medical schools, there's a growing trend to have interprofessional education, at least some classes that call that. And so we thought that could be built up on, bring in some of the other professions that aren't already represented, and make sure that pain is part of that. And we talked about exchanging trainees. So, again, as an example, we might have the occupational therapy program send their trainees to the pain center, and the pain fellows might spend time in the occupational therapy program, and that's just an example. All the different professions could do that. At UCLA, they have a large arts and healing program, and so there was some discussion about how they do outreach to go out into the different professions and educate them about what they offer. And that model could be used by others too, to essentially do outreach about the services being offered. Then we talked about maybe doing collaborative programs. So for instance, maybe a pain center and a physical therapy center might join forces to do a collaborative symposium. I think before we talked about primary care and pain programs could maybe join forces to do symposiums, CE, CME programs. It was pointed out educationally it'll be more effective if it has experiential components to that. Let's see here, and then we talked about trying to include the patients in the education. I think most med schools already do some of this, but not necessarily with pain. They may bring a diabetic into the endocrinology course and have that person share their experiences. So using these types of programs, but with pain patients, could also help a great deal. And one of the things we talked about is that you can have all these CE programs, you can have all these volunteers willing to offer their services, and nobody knows about it. So the idea of an online hub that would go out there and try to collect all the different opportunities so that if somebody's interested, they could easily find the resources. And one of the ways that we talked about to market that is that a hub like this could exchange links or information with various professional societies. So the psychology website might have a link to the Pain Hub, and the Pain Hub would have a link to them, so everybody feels like you're scratching each other's backs. And I think that about covered the topics that we covered in the pain education.
Thank you. That was fantastic. Okay, so what's the next part? The next part is going, would you do me a favor and put those up on the, thank you, Steve. You were coming to do it, right on top of it. We've got some fantastic volunteers here today, and we just wouldn't be able to pull this off without them. Let's give them a big hand. They've been here since early this morning. You guys rock. Thank you. So I mentioned the commitment sheet. So if you have begun to put some things in these boxes, great. There's two ways we want to capture your interest/commitment. One is by what you put on this form. So if you would take a few minutes to add to it, this is something we'd like to collect. The second is somebody came by and handed you a series of dots. You should have 3 sets of dots. If you don't, raise your hand and we'll get you some other dots. You'll have green dots, you'll have blue dots, and you'll have yellow dots. The green dots are, hey, I'm ready to go on this idea, or we're already doing it. The blue dots are, well, I think it might be something we can add, but it would be in the future. And the third is, well, if we had some funding or some collaborative partners, then maybe we could consider that. So all those ideas that you heard about are spread out on those flip charts. And so we'd like you to just do a quick gallery walk. If you see it's crowded up there, just work on your commitment sheet. So the information that you've generated, we're going to turn that into a list, turn it around. We'll let you know what level of dots, amount of dots. We'll also take the commitment sheets, and that way you'll have some idea of who those dots represent. And we'll put them together and turn them around and send them out to you. And then the folks who volunteered to share their contact information with the people in the room, we'll put that together and we'll send that out to you as well.
So as far as long-term, bye, Rhonda. What's to come, next steps, we need to convene a white paper committee, and I've been working the room, and I have 2 members already. And one, I'll do as much as I can, so that's really great, yay. Then we need to craft that white paper. We need to recommend steps for implementation of a national pain strategy in California, whatever we think is the best strategy for California, right? That makes sense. As well as follow up with legislation. We heard from great staffers today about what they loved. Most of the staffers said, we had no idea. I had no idea that pain could be severe like this. I didn't even know about pain except as a symptom to an underlying problem, right?
So we expect bills to come out of it. I know I'm supposed to be going fast, but I will go on. Okay, you must stop me. So I just wrote down, follow up with legislators and staff about what has come out of today's conversation. Thank you.
Why don't you give some thanks, and then I'm going to close us out with a quote.
Oh, I thank you, California Endowment. We love this venue. Community partners, Rich Tamayo, tvplive.com. Please go hire Rich. You're great. Woo! And Jay, we love you, Jay. Even though I just met you, I love you. Okay. The Mighty, thank you for your videos. We need to be showing the Mighty videos. Okay. Volunteers, I bow to you. You are so amazing. You come back every year. We give you more work every year, and you come back for more. It's just, I love it. I love it. Speakers, were these speakers phenomenal? Yes. Were these, I mean, participants, thank you. I'm going to cry. I'm just so moved by your smile, Steve, and just your love and care. And really, it's your being here today and participating that will make all the difference. And people with pain will have a totally different outcome, honestly, in the future because of this day, because you people really care. I'm in complete, absolute awe and humbled. And especially by you, Mindy, my beautiful sister. Thank you for coming to me and knocking me out of my comfort zone. I love to be here, and it's working, right?
Thank you.
I love
well,
you.
today wouldn't have happened unless all of you showed up. So thank you so much for showing up. We've worked on this for about 2 years, from the idea to this.
Remember, Diane?
And so just thank you for making all that work worth it. I want to leave you with one quote. The quote I had at the end, somebody else used, the Margaret Mead quote. So I am going to go back to this quote. It's by Goethe, and I stole it from the Institute of Medicine, now the National Academy of Medicine. This was from the report in 2011, and it says, "Knowing is not enough. We must apply. Willing is not enough. We must do." So go do. Thank you.
Thank you, and thank you, Radine Marie Cook, for your art. Thank you, everybody, so much. Let's keep doing the work.